Thanks, everyone. My name is Jim Dunn, and I'm the director of the McMaster Institute for Health Equity. Very pleased to be here and very pleased to have our guests today and welcome all of you who have joined us online today. Thank you very much. I want to start off with a land acknowledgement, and we'll begin by honoring and giving thanks to the Haudenosaunee and the Abenishaba nations as the traditional inhabitants of the lands where McMaster stands. And to say that is to acknowledge a debt to those who were here before us and to recognize our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have had to this land. And so for me personally, having grown up in this area, this means a lot. I spent a great deal of time on these traditional territories in the undeveloped areas, I guess we would call them now, conservation areas and so forth. And I think, although I was unaware of it at the time as a child, I now look back on those times and think about how important these lands were and these territories were to our Indigenous friends and colleagues, and how important they are going forward for us to share in the stewardship of this area. So thank you for joining us here today. So this seminar is part of the seminar series for the McMaster Institute for Health Equity, and it's co-sponsored by the Center for Advanced Research on Mental Health and Society, which is led by my colleague, Marissa Young, who's here today. And we're very pleased to have as our guest, Dr. Andrea Gonzalez, and she will be presenting, but also part of the research that's coming out of the presentation is Megan Kenny as well. So Andrea is an associate professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University and a member of the Offord Center for Child Studies. Her research program focuses on the developmental consequences of early life adversity, intergenerational transmission, and evaluating evidence-based preventive interventions. She holds a Tier 2 Canada Research Chair in Family Health and Preventive Interventions. Now, her presentation will highlight key considerations of health equity when implementing new community programs, including health equity impact assessments as a tool to use prior to implementing programs, lessons that they have learned, her team has learned through community work and building community partnerships, as well as identifying and addressing barriers and facilitators to service access for families with young children. So if I could pass it over to you, Dr. Gonzalez, we can get started. Thanks so much for being here.
Great. Thank you so much, Jim. I just want to make sure everyone can see my slide. Yep. Okay, perfect. So thank you so much for the invitation to present today, and Lindsay for all your organizational efforts. It's great to be here. As Jim mentioned, I am the person who's presenting today, but my silent co-presenter is Megan Kenny, who's one of our senior research coordinators and is here on the call today, and but has been sort of co-leading and doing a lot of the work that I'll actually be presenting today. So in addition to Megan, I'd like to start off with acknowledgements. It's a huge team really that make all of this work happen. My kind of research co-investigators from McMaster and the University of Manitoba, as well as, a whole host of trainees, undergraduates and graduates and postdocs, as well as my wonderful research team that really bridges everything and makes it all happen. And we are funded by the Public Health Agency of Canada, and all of the work that I'll be presenting today is funded by them. So when I first started this project, it was my real first foray into intervention and community work. And it had so many moving parts that I was, to be quite honest, a bit freaked out by it. And then a wise person told me to embrace the messiness. So thank you, Jim. I don't know if you remember that conversation that we had. So I did just that and pulled our entire team into the messiness with me. And really, for the last 4 years, we've gone down this rabbit hole, which has been a really amazing journey and very enlightening and humbling in terms of the work that we have been doing. So why embrace the messiness? And really, it's because life is messy. Life is messy for children. Life is messy for families. And I love the logo from the 2014 Ontario Child Health Study. because the different colors of thread represent all the domains and areas that touch a child's life. So home and school and neighborhoods and communities, and it's all a squiggly mess. When we think about children's lives, it's like putting them in the middle of an onion, or in Brockenbrenner's model, that show the different layers of things that can be impacting a child. So we have the layer that's closest to the child, so the microsystem, which includes the family, the classroom, perhaps religious settings, their peer group, which get increasingly important as they get older, which I now know that I have an adolescent. And then we have the mesosystem, which is really the interaction of all the different microsystems, the exosystem, which are the services that touch the family and children's lives, and then society and culture that we live in. And when you put all these factors together, what you see and what you get are all these interactions and the messiness really of people's lives. So we know that there are many, many factors that influence health. And in addition to our individual genetics and lifestyle choices, the social determinants of health, so where we are born, where we grow, live, work, and age, have an important influence on our lives and our health. And you can add social determinants of health to each of these layers. So things like family SES or income, social protection, education, food insecurity, housing affordability, early education and care, work-life conditions and balance, social inclusion and non-discrimination, structural conflict, and access to high quality and affordable health services. So I'm going to start with a bit of a poll, and this was something that one of my postdoctoral fellows, Amber, helped me put together because I'm technologically incompetent. So I think if you either use your phone and you go to the QR code, it'll take you directly to the website, or you can go to Pigeonhole, and then you can enter the password 1111. And it will take you just to a couple of questions that I have. So the first question is, what do you think is the biggest contributor to individual health? So do you think it's biology and genetics? Do you think it's the social determinants of health, lifestyle, or healthcare access? So access to the healthcare system and stuff. So I'll just give it a few more minutes. I can see, not minutes. You can see there's 10 participants still voting. So we're getting really overwhelming. I mean, not surprising considering the audience, but the social determinants of health, even though the graph is changing and bouncing back and forth a little bit, you know, it's overwhelming, the social determinants of health. Okay, so you're right. You know, when we think about what influences health, it's all those outer layers of the onion peel that really matter the most. And only 15% is actually related to biology and genetics, whereas 50% of the influence on our health comes from factors in our life. So all of those social determinants of health that I was just talking about, income, early childhood experiences, social status, education, nutritious food, housing, and community and belonging. 25% of the influences in health are attributed to access to healthcare and quality of our healthcare system. And 10% is due to things in our environment, such as air quality and civic infrastructure, although I imagine that that's going to be changing with climate change. So in 2011, the Canadian Medical Association created a national dialogue on healthcare transformation and you know, did a study across the country about what makes us sick. And really that they found that exactly these kinds of statistics. And even though this was done now over a decade ago, all of these percentages still hold true. What's important to note is that these risk factors, or socioeconomic risk factors in our physical environment, health behavior, and healthcare, they don't operate in isolation, but really intersect or are compounded within single individuals. So poorly performing health systems can be a major barrier to healthcare, and it's a critical social determinant of health. And we know that individuals are not accessing healthcare in the same way. Many of the reasons due to some of the social determinants of health. And it contributes to the burden of illness. And really, a well-performing healthcare system can help increase equity to healthcare access and improve outcomes and improve health equity for all people. And this is really what we've been learning. Many of you obviously know this already, but with our community work, we're really trying to address this. So I have one more poll here. So if you go back either to the website or to the QR code, and again, enter the same password, 1111. The next question is, what does health equity mean to you? So if you could, I guess some people already started answering this, but so we've got eliminating barriers, flourishing, justice, well-being. I can see inclusivity is coming out as a bigger word and darker, accessibility, availability to everyone, and access to healthcare for everyone. So that's great. So my son, it's interesting that I was asked to give this talk, and especially at this particular time, because my son, who's in grade 7, is actually learning about health equality right now in geography. And a couple of weeks ago, we were reading about quality of life and how Canada, being a high-income country with universal health care, is a country that promotes equality, and we have a high quality of life, which is true. But it doesn't necessarily mean that there's equity. And that was something that I was trying to teach him, because when we think about equality, equality means sameness. So it's giving everyone the same thing, which universal health care is. And really that only works if everyone is starting from the same place. And we know that that's not really the way life works, and that we have to really be thinking in terms of equity and in terms of fairness, so that access to the same opportunities mean that people aren't starting from the same place, and that we have to be thinking about equity when we're thinking about the programs that we're implementing and that we're developing and that we are kind of rolling out into the community. And really, health equity is only achieved when there's no difference in an individual's opportunity to obtain good health and access to these programs. So how big of an issue is health equity in Canada? I've just pulled up a couple of statistics that are probably familiar to many of you, but we know in Canada, nearly 1 in 5 children live in poverty, and that income and poverty is a major factor in terms of equity. And that poverty discriminates even further based on race and ethnicity. So that poverty amongst racialized children is actually at 22%, and amongst landed immigrants and newcomers and permanent residents, it's 35%. And if we think about First Nations and Indigenous children, almost 50% on reserve are living in poverty, and 41% off reserve are living in poverty. We also know that wait times for Ontario's children and youth are seeking mental health services are long. About 28,000 children and youth were on wait lists as of January 2020, and that this figure has more than doubled had more than doubled since 2017, and it's only getting worse in many ways because of the COVID-19 pandemic and the need that's actually out there now. And that on average, the wait is 67 days for counseling and therapy and 92 days for intensive treatment. And where you live in this province really matters. That wait times can range from almost immediate to over 2.5 years. So that's an equity issue when we're talking about urban and rural disparities as well. And we know that there are individuals that don't even make it to the wait list for many, many reasons. And really that's the focus of the work that we're doing now. Not that we address wait times directly, but we really try to look at equity as we're rolling out programs within the community. So today I'm going to be specifically talking about a study called the Promoting Healthy Families Study. It's one umbrella study for different sub-studies that are embedded within it. But one of the main studies within it is a 3-armed randomized controlled trial where we are comparing 2 parenting programs for caregivers of children ages 2 to 9 years across the province. And there were many, many different steps that were involved in this one particular project. We started off with an environmental scan to even understand the landscaping of parenting programs across Ontario, because we were interested in particular in one type of parenting program called the Triple P parenting, but Triple P themselves actually couldn't tell us where the program was being offered. And so we did an environmental scan to understand what programs were being offered across the province. And we found out that many organizations were also offering a program called Circle of Security parenting program, and that it didn't have as much evidence, which is how we ended up with a 3-armed randomized controlled trial. Doing the environmental scan was really an amazing kind of experience because we got to develop many different partnerships with community organizations across the province. And then we specifically partnered with 3 lead mental health agencies and another community agency that offers programs to families in their community in order to implement the 2 parenting programs and to partner on the research end of the project with us. But prior to implementing the program, we conducted a health equity impact assessment because with each of the 4 organizations, because we wanted to examine the unintended health impacts of potentially health impacts of implementing the programs in these communities and in these organizations. Then we trained the providers, and now we're conducting the 3-armed randomized controlled trial with just over 500 families in Ontario. And in parallel to the RCT, we're running a process and an economic evaluation in order to see what works for whom and why, and to understand what programs are sustainable. So phase 1 of the study was our formative evaluation, which was guided by the quality implementation framework, where really phase 1 is initial considerations of the host setting. So we created the structure for implementation, which provided the basis for the formative evaluation, and it is where we kind of place the health equity impact assessments. And we also did a community readiness analysis, and we did provider and organizational readiness analyses as well. But today I'm going to speak specifically about the health equity impact assessments that we did. So for those of you that don't know about health equity impact assessments, this was a tool that was specifically developed by the Ontario Ministry of Health and Long-Term Care. And it's really meant to be conducted prior to implementing any new policy, program, or initiative. And there are four main purposes for conducting a HIA. One is to identify any groups that may experience unintended health impact as a result of offering the program or service. The second is to determine what the potential unintended impacts might be, either positive or negative, to generate strategies based on evidence that might mitigate these impacts. And finally, to evaluate whether the mitigation strategies were implemented and whether or not they achieved their intended goal. So this work was done by Megan, and really she is the HIA expert in our group. And it was an immense undertaking to conduct 4 separate HIAs with each of our partner organizations. It is a multi-stepped process, and the very first step is conducting a thorough document review. So we requested documents from each of the agencies, including things like their clinical policy and procedure manuals, any annual reports that they might have had, or strategic plans, as well as human resource documents that were related to health equity, hiring practices, and staff and training opportunities that they were offering. After completing the document review, a series of key informant interviews were held with the agency staff members, as well as independent community partners that are familiar with the catchment area and the work being done by agencies. And our interview guides were all informed by the HIA workbook from the Ministry of Health. And we made some modifications in order to really kind of tailor it specifically to parenting programs per se. We also consulted with community practitioners with extensive experience in delivering parenting programs, and in particular groups that worked with Indigenous families. Megan then did all the syntheses of the findings from the document review and the interviews into a report for each of the agencies, which included evidence-based recommendations to address some of the inequities that were identified. And prior to finalizing the report, the drafts were shared with the agencies, and all the information that was summarized was shared so that they could each kind of comment on it. And there were individual meetings held with the executive director to review the findings and to propose, the recommendations kind of moving forward. And finally, we are incorporating the data collection to kind of measure, which I'll talk about in a minute, the recommendations that we put forward. So one of the first steps that we did was we wanted to get a sense of really what was the diversity of the catchment areas that our partner organizations were serving. So we hired a geographic information specialist who used the Ontario Marginalization Index data and the 2016 census data to conduct a detailed description of each of the catchment areas of the participating agencies. And specifically, we looked at material deprivation because it's closely linked to poverty and includes measures such as income, quality of housing, educational attainment, and basic material needs. And we looked at ethnic concentration. So whether or not an area was had a high concentration of people who were recent immigrants and or people who are belonging to a visible minority group. And both of these measures are based on a quintile distribution which is a measure across Ontario, where 1 is the least deprived or ethnically concentrated, and 5 is the most deprived and ethnically concentrated. And then he pooled all the information together as well. And we found that the combined population of the 4 catchment areas of our participating agencies was over 3 million people. 2 of the agencies served primarily urban areas, and 2 served urban rural areas. So 2 were actually covered almost all of the GTA. And then 1 is in the Niagara, St. Catharines region, and the other one is in Windsor, Essex. So material deprivation for all sites were skewed towards higher deprivation amounts from 2.99 to 3.37 on that 1 to 5 scale. And all agencies served racially and ethnically diverse communities. So after conducting the HIAs, even though there were individual reports that were generated for each one of our partner agencies, we kind of collated the main findings, and that's what I'm going to be presenting today. And some of the groups that we identified as potentially experiencing unintended health impacts include caregivers from diverse racial and ethnic and cultural backgrounds. So as a warm-up question, Megan would ask the interview participants for the HIA to describe what kinds of communities that their agency was serving. And what we know both from the GIS analysis as well as the interviews is that, excuse me, that the communities in the catchment area were incredibly racially and ethnically diverse, but that's not the families that were actually coming through the doors and that were accessing services in most of the agencies. What we were finding is in 3 of the 4 agencies that the families that were actually accessing services were predominantly white. So 94% of the families were white or Caucasian. So, the focus of the rest of the presentation will be what we did to kind of address that. But in terms of other groups that were potentially experiencing unintended health impacts, we also found, caregivers with low literacy levels because of the heavy component of homework and the psychoeducational component of it in the workbooks, that they might be at a disadvantage. Caregivers living with mental health and or addiction issues, families living in remote and rural areas, caregivers who experience financial difficulties. We also found the timing of the group sessions was problematic. Many of them were being offered through the work week and during a work day. So for families who were working full time, that could be problematic. We were also surprised to find that really there was just an overall lack of awareness of services that might be contributing to the lack of diversity that they were seeing, and that there were transportation and technology issues during COVID. So some of these we addressed pretty quickly with our partners' support. And I have to say, our partners are absolutely fabulous, and we're very open to many of the, the feedback and the strategies. So we were able to convince some of the partners to offer evening sessions and a Saturday session as well, so that there would be more flexibility. And that with the technology issue, because we did launch with COVID almost at exactly the same time as the pandemic was declared, was our first wave of groups, we were able to pivot very quickly. And for families that didn't have access to technology, we purchased iPads with Wi-Fi and were able to supply that to them. So we don't have time to review all of the unintended health impacts and the mitigation strategies, but we wanted to provide just a few examples from the final reports. So, for example, one of the groups that was identified as experiencing unintended health impacts were caregivers from racialized groups. And so, many of the group concepts might not be considerable as acceptable parenting practices across various cultures. And so participants might not feel comfortable with some of the concepts that are being taught, and then it would affect, engagement with the program. So one of the mitigation strategies to address this was that providers were able to participate in coaching sessions that were led by the parenting program representatives to help them navigate conflicts and between program concepts, and to talk about the cultural values to families that might be from different ethnicities. A second population that might have an unintended impact was caregivers with a history of childhood trauma, and that some of the self-reflective work that comes up in the programs might trigger some of the caregivers around their own childhood trauma experiences. And how we had a mitigation strategy for that was that two providers were able to facilitate each group, so that if anything ever arose, one would be able to continue to run the group and another would be able to support any caregivers who might be activated by the group material. We've also worked with a lot of the providers to also be offering pre-group kind of consultation sessions, either if a parent wanted to talk about materials that they found particularly difficult or challenging, or if a parent actually missed a group because of scheduling issues. And that was something that was not naturally done with most of the agencies that we partnered with. And finally, with caregivers who were experiencing financial difficulties, again, accessing the technology might have been difficult or impossible, so we provided the families with iPads. In order to do that last part of MIHE, which is the step 4, which is really to evaluate your mitigation strategies to see if they actually worked, we're trying to do that in 2 different ways. One is through caregiver satisfaction surveys at the end of all of the groups that are being run. And finally, we've incorporated questions with the one-to-one interviews with parents and the focus groups with providers. That's part of the process evaluation, so that we'll be able to specifically look if some of our mitigation strategies worked. There were many agencies that were very aware of the fact that they had this discrepancy between the catchment area that they were actually serving and the families that they were seeing. And when we interviewed the agencies, they were really all concerned about their inability to engage racialized families. And we're at very different stages of implementing strategies to address this issue. So some of the strategies that they were sort of either considering or were in various stages of implementation was to increase translation services that were being offered in the community and advertising services in other languages, to advertise the services in areas with concentrated ethnically diverse kind of families. Many were participating in public health community events where various healthcare providers could conduct health screening for children. And that had been put on hold during COVID, but now is sort of being slowly kind of implemented again. Some of the agencies were forming parent advisory groups to inform service delivery and to advise on what's working and what needs to be changed, and where the services could be changed. And one agency in particular had invested a significant amount of time and resources into engaging the Black community. And this involved closely working with a consultant that helped overhaul their hiring practices and revised policies around inclusion and safe work environments. And all the agency staff members were involved in anti-Black racism training. One of our agencies also had recently relocated to an area that really wasn't amenable for families to actually reach in terms of where their main office was, and took them out of the kind of community that they were used to serving. And so they had seen a drop in the number of Black families who were seeking services after this move. So they were trying to address this by purchasing a satellite site that was going to be staffed entirely by Black social workers in an area, that was predominantly Black families. Another agency already was implementing many successful strategies and approaches for engaging diverse families in their community. So they were making sure that the staff members were from ethnic backgrounds that reflected the diversity in the communities that they served. They also had many trusted partnerships with other organizations in the communities that touch families' lives, so schools and libraries and places of worship. And they were regularly hosting pre-COVID cultural celebrations throughout the year to mark important events for ethnic and racialized groups in the community where food was included. Other strategies that we're already working with some of our partners was pairing families with providers from the same racial and ethnic background, offering interpretation support immediately to families when they come, co-facilitating programs, and applying a strength-based approach. So in order to address some of the things that came out of the MIHE, we took on a targeted advertising campaign to raise awareness about the Promoting Healthy Family study and the parenting programs that were being offered. We also conducted a scoping review to identify barriers and facilitators to engage racially and ethnically diverse families. We designed a community engagement framework in collaboration with a consultant. And we formed a working group composed of members from a coalition of service providers in one of the areas that our partner agency worked. So I'm just going to briefly touch on each of these points. So one of the first rabbit holes we went down was this advertising campaign. It's funny how many skills you actually have to bring into the research realm. One of the very first things we did was we worked with an advertising company who I would have to say the very first set of kind of ideas that they brought us were a little bit scary. So we went to the literature and we did a search on, what works with families or what worked in other research studies that were really focused on recruitment efforts of ethnic and racially diverse families. And really we found pretty consistent messaging that it should be strength-based messaging that has diverse representation if you're going to have pictures and are easily accessible. So working with, our partners and this advertising firm, we came up with a series of ads to promote the study. And we had a landing page associated with this particular aspect of the study called Raising Strong Kids, and you could have a QR code. It was also shared through social media as well as kind of hard copies, but I'll just quickly scroll through them. But our message was recognizing that parenting struggles is easy and finding the solutions is harder. We're still all learning together, so let's learn together. Parenting is a journey, and knowing where to go next would be great, right? We've got a great roadmap to help you. Parenting is complicated, and this year has made it even more so. Find out some parenting strategies to help simplify it. So you can see our message really wasn't about problem behavior of the child, or it was really like parenting is challenging, but let's work it out, and let's give you some strategies that might be helpful. And all of the photos that we were choosing were really trying to address the ethnically diverse aspect of it, but also very positive kind of parent-child relationships. So another thing that we wanted to take on was to see how much was in the literature in terms of barriers and facilitators. And so a group of students conducted a scoping review where we really wanted to look at barriers and facilitators related to the engagement of racial and ethnic minority children and their caregivers and mental health services. And we limited our search to studies that involved younger children or parents of younger children ages 0 to 12. And the studies had to include a discussion of barriers and facilitators. And we only looked at qualitative studies because we wanted to look at, what kind of stories were essentially emerging in relation to the social determinants of health, barriers and facilitators, and any kind of recommendations that might have come out. So after the initial screening, 18 articles met the inclusion criteria. And this is a beautiful figure that one of the students, Shibrit Johal, put together. And I have to say, this was 3 undergraduate students that did this along with Megan Kenny, and they just did an amazing job. And they've all gone on to graduate school or medical school now. But some of the barriers they identified were things like stigma and lack of awareness and inaccessibility. Some of the facilitators were anecdotes, so strong supports of, a strong network, having, positive group interventions. Facilitators were also awareness of services and having accessibility support, so providing ways to the services, so transportation, flexible scheduling, providing childcare so that parents could attend. There was an overlap between individual and systemic barriers and facilitators, so that the barriers are mistrust, having just poor previous experiences with healthcare individuals or providers, and not having any kind of encouragement to attend programs for mental health. But on the flip side of that, education and having trust in services was a facilitator. And at the systemic level, lack of cultural accommodations and representation of ethnically diverse staff and employees is a barrier, and cultural competency, is the complementary facilitator. Whoops. Oh my goodness, what happened? Sorry. So our other real kind of deep dive and another rabbit hole we've gone down is to engage in our own community engagement strategies. So we partnered with one of our organizations and agencies, and we they wanted to understand better why they were struggling to engage racialized families. So we hired a consultant that was specializing in community engagement work to help us to design an engagement framework. And you're not really supposed to be able to see this. This was sort of all the sticky and whiteboard kind of notes that came out of our day, but we had individuals and the executive director from the agency that we were partnered with, as well as individuals from other community organizations who helped us sort of during this workshop and to figure out, what were our next steps and what our framework should be, with the ultimate goal of being, how do we engage diverse families and services? So really the first step was to identify barriers and facilitators and generate strategies based on participant feedback to address these barriers, and then to disseminate the findings to our community partners so that service providers can learn how we can be working better to engage racialized families. So Megan has worked very hard with an advisory group that was formed with our partner agency, and this advisory group has been fabulous because they helped us decide how many languages we should be offering our focus groups in. So now we're running focus groups in 8 different languages that represent the community that everyone serves. They're helping us determine the recruitment strategy, working very closely with us to help recruit families, and helped us craft the wording and the content of the study materials, including the informed consent and the interview guides as well. We also have community translators who are going to be co-facilitating these groups. They're going to be launching in about a month. And really the ultimate goal is to share all this feedback with the advisory group so that we can get their interpretation on the data. And the translators have actually been incredibly helpful as well, and to help inform and shape the plan for disseminating the findings as we move forward. Just very quickly, another part of our study is actually looking at pregnancy to the early years. This is with a different set of partner agencies. We have 5 of them across Ontario and Quebec. And it's focused more on high risk pregnant and new mothers who are really facing a lot of those social determinants of health that I was talking about in the earlier part of the presentation. And in this study, we're implementing, it's called the Parents Under Pressure study that was developed in Australia, but we're looking at the feasibility and acceptability of this program in Ontario. Some of our initial work has already identified that pregnant individuals facing social determinants of health seek prenatal care late and are at increased risk of mental health issues. And that really in Canada, pathways to services are not well articulated. And this has come through some of reviews that we've been conducting and looking at, but it also has come through some initial interviews that we've done with the providers across these 5 agencies. And they've identified barriers for the women that they serve, including fear of judgment and fear of losing their children to the Children's Aid Society or Child Protection Services due to intimate partner violence or other factors, including housing instability. They also identify barriers such as lack of community awareness. Again, many of the women in their program come to their programs quite late. There's also wait lists for services and a lack of housing that's available for these women. So it's hard to work on parenting when they've got so many other needs sort of happening at the same time. What this has sort of led to is a greater understanding that there are gaps in the provincial referral pathway, in part due to primary care not connecting with these individuals until much later. So we are now working on a pathway based on the provincial perinatal pathway and trying to simplify it and gather resources for the communities and sort of house them in one repository so that it's easier for people to navigate. And there's a quote from one of the providers here that says you have to plow the path for these caregivers. There isn't a path and there's no real destination at the end. one of the recommendations that came out of some of these interviews was conducting early screening for social determinants of health and trying to make those connections to primary care quite early and going to where some of these caregivers are. So I'm going to skip over this for the lack of time because some of this you can find on our website. But we know that these gaps exist. We know that marginalized families and vulnerable families really aren't engaging in our services, and the COVID-19 pandemic has just amplified that even more, and that really we need to be doing a much better job at addressing these kinds of long-standing issues. And that these occur at multiple levels. So across all of our studies, we found that families are struggling to meet their basic needs, and they really don't have the time or the resources or even the mental space to be accessing services and participating in the kinds of programs that we're offering. Because if you think of Maslow's hierarchy of needs, their bottom need about housing and security and food isn't being met. So how can you possibly work on the top portion? There's also lots of systemic challenges, including a lack of provincial pathways that are very clear and easy to navigate. There's limited resources and funding for these services. And then there's accessibility issues that are either cultural or logistical, as well as the stigma that's attached to needing mental health services. So we've sort of, created a list of recommendations, which are probably familiar with you all, and we're really trying to work on making some of this happen. In terms of advocating for increased resource allocation. Even some of our work with the community agencies has moved the needle a little bit in terms of having them understand that they need to offer more flexible services. And I think, these wonderful partnerships that we've developed in terms of how do we improve community engagement is also moving the needle a little bit. So I'll just skip through this. It's not that Ontario isn't investing in mental health, because our government has, announced, a multi-billion-dollar investment over 10 years as their roadmap to wellness and mental health is a large part of that. And last year they announced 31 million to help improve access to mental health services. Part of the problem is that we're still working downstream here. All the mental health services are going into services, which is the budget's going into mental health services, which is very much needed in order to reduce those kinds of wait times that we were talking about, but we need more support upstream and really to address the social determinants of health in order to make a real difference at all. So finally, I'll go back to this diagram and, highlight this last box about justice, that, this is what we should be working towards. We should be removing the barrier altogether so that everyone can have access to services, because all the causes of inequity have been addressed and the systemic barriers have been removed. So thank you. I haven't much time for questions, but I'm happy to take questions.
Great. Thank you so much, Andrea. We do have a few minutes that we can take questions. Okay, I'm just trying to distinguish the clapping hands from hands raised at this point. A 21st century hazard there. Oh, so far, just clapping. Any questions?
I think people should feel free to unmute yourself if you have a question.
Oh, we've got one from Peter Rosenbaum. Thank you, Peter. What was the single biggest aha for you?
Yeah, that's a great question. I think because this community work so new to me. I think the degree of the discrepancy was the biggest, not even aha moment. It was just the biggest smack me in the head kind of moment. And that, I don't know, because then since then I've spoken to many people who have been doing clinical work and these kinds of programs for many years, and they were kind of like, oh yeah, well, how do you not know this? But it's just that families aren't even accessing services. So where are they getting help? And that is one of the, I didn't talk about it today, it's one of the things that we're trying to also address is to, be having almost a stepped care model for the parenting services, because if we're only seeing such a small percentage of people coming in the doors, then how can we be reaching parents, even if it's through the lightest touch intervention, or to decrease stigma, or to increase awareness of services. So I think it was just how big the gap was the biggest kind of aha moment for me. I don't know, Megan, if you want to add to that, because you were sort of in the trenches with the.
Yeah, I would agree. I think I haven't worked in this area before this study, and so for me, learning that a lot of these organizations, their community partners as well, were struggling to engage racialized families. That to me at the time was quite shocking, but then getting into the scoping review and talking to more people, it's obviously an issue that is quite well known. I think what in the scoping review, what really stood out was there was a lot around what the barriers are to engaging these families, but there isn't a lot around action and what can be done to address it. And I think in working with the community partners that we've been associated with, that's something that they're really hungry for, and they want to know what they can be doing. And I think that's where there's a huge gap right now.
Yeah. And just to add to that, we've just recently received, a number of us that are here, including I see Kathy as well, received a Catalyst grant to develop a framework for mental health for racialized immigrant and newcomer families. And we, one of the things our team has been talking about is we know the barriers and we know the barriers, like Megan had said, but it's how do we get past those barriers now, and how do we develop guidance documents that are meaningful to agencies and people who are providing services to actually break those barriers down. So it's sort of where we're kind of going right now. So
I'm going to go to the chat for one more, and So Yin Min has a question. Any tips on how to use translation interpretation services effectively, especially in a group setting? Language barriers are huge issues in terms of accessing mental health care.
Yeah. Megan, do you want to talk about the interpretation, or, interpretive services are extremely expensive. Very, very expensive. So I don't know, Megan, do you want to talk about some of the experiences? Well, even the preliminary ones with the translators, like how we've had to...
we've been really fortunate in that the organizations that have come on to support the community engagement study have offered the use of their translators to assist with recruitment and to assist with facilitating the focus groups. And I think their involvement has been crucial. We've gone back actually after meeting with them to revise our focus group questions based on their input from their specific communities, what will work, what will not work. I think that's been really valuable, but it's a huge expense, and we've been fortunate and for this study that we have that support from the organizations that are involved.
Yeah.
Okay, well, thanks. Just because we're at time and we're probably going to start losing people, perhaps we'll wrap it up. And I want to thank you, Andrea and Megan, for joining us today. It was a really, really fantastic presentation and just incredibly impressed at the way you have slogged through the messy, as it were, and embraced it. So that's very kind of you to reference back that conversation we had, and done a heck of a good job on doing that. But it doesn't go away easily. Let's put it that way. I think you're learning, and that's definitely the case. So thanks again. I'm going to pass it over to Lindsay for the closing comments, and thank everybody for joining us, and hope to see you all again soon at a future event.
Yeah, it'll be fast, but just everyone who's registered for this talk, which is everyone here, will once it's available on YouTube, we'll send it out to you by email. And a quick reminder to the students in Dr. Singh's course to please reconvene on a separate Zoom link, and you can meet with Dr. Gonzalez and Megan to continue the discussion. And thanks, everyone.